welcome to the Independent Sage Friday briefing. This week, hope of a viable COVID vaccine made a significant step towards becoming a reality. The news arrived at the same time that the UK became the first European country to pass the grim milestone of 50,000 official COVID deaths, a disproportionate number of which come from the most deprived communities. In addition to our regular panel of experts, we welcome Professor Clare Bamborough and Professor Alison Pollock, who will be sharing the Health Inequalities Report, which they co-authored on behalf of Independent Sage and which delves into this discrimination. As always, Indy Sage's panel of eminent scientists will be taking questions from the Minister and the public, as well as our special guest, Shadow Health Minister Jonathan Ashworth. So thank you very much for joining us today. There is much to discuss this week. Let's start with a look at this week's figures, which will be presented by Professor Christina Pargle.
Hi, everyone. Let me just share my screen. So I hope you can all see that. So really, the headline this week is that everything is really uncertain. So what I'm going to do is I'm going to go through deaths, hospitalizations, and then end by looking at cases and kind of dig into them within nations and kind of looking at where and who is getting infected, and basically just take you into my uncertainty. So starting with deaths, these are weekly registered deaths from the Office of National Statistics. These are kind of the gold standard, and they go up to the 30th of October. We can see that the pattern we've been seeing since September is continuing, where the number of deaths is doubling every 2 weeks, basically. And that is the same for England, Scotland, Wales, and Northern Ireland. If we wanted to look at more recent data, then we look at deaths by date reported. This is just the data for England. And you can see here that that same doubling pattern is seen here. There's a slight sign that it's slowing down. Maybe, you know, we went from 2.2 thousand the kind of last 2 weeks of October to just over 4,000 the last 2 weeks to yesterday. But, you know, it's a pretty relentless increase. And as we'll see, although there's signs that things might be slowing down, hospitalizations and cases are still increasing slowly. And so it's unlikely that deaths are going to come down over the next week or two. They might level off, but unfortunately, deaths are continuing to go up. Hospitalizations. I'm now showing this for all the nations. Note that the Welsh figures cannot be directly compared to the other nations because they include suspected cases and the other nations don't. And they're also much kind of bumpier, as you can see. And this is per million people per day, daily average. And I'm just kind of going to show, oh, hang on, I need to go back. What you can see is that Wales has kind of stabilized over the last few weeks. Scotland and Northern Ireland stabilised, and it looks like they're coming down, which is really good news. Scotland, both of them about 3 weeks after they did their kind of latest restrictions. England is still going up. It looked like it was kind of levelling off, but the last few days we've seen more increases again in hospital admissions. So looking at England, you can see that here, that this is when it looked like they were levelling off, but this week we've seen quite regular hospital admissions over 1,500 a day, which is quite high. And if we look at where that's happening in England, it's happening in the northeast in Yorkshire. That's continuing to go up quite high. The Midlands is accelerating, and it's going up in the southwest of England now as well. It is coming down in the northwest and steadying off in London. And if you look at when the restrictions came in England, so the tier system came in 14th of October, London went pretty much straight into tier 2, and some of the northwest, not all of it, went into tier 3, particularly Liverpool, but then other places followed it. Most of the North East and Yorkshire stayed in tier 2 for this time, and it doesn't seem to have slowed down hospital admissions really at all. And the Midlands was kind of a mix between tier 2 and 3. So this is when I say it's really difficult to know what's going on, because it seems to have worked a bit in the Northwest and in London, but not in the Midlands and the Northeast. And the Southwest, which has been in tier 1, has now got quite a few more hospital admissions per head than London. And what this means is that although hospital admissions have been rising less quickly than they did in March, because people stay in hospital with COVID, between a week and 2 weeks, it means that the number of people in hospital at any one time is building up and building up and building up. And we're now at 2/3 of where we were at peak in April. And this is now starting to cause problems. So we can see, hospitals in the north are having to start suspending surgery. And there's also warnings in the southwest that they are close to their hospital capacity. Looking at cases now, this is the whole of the UK, number of people who've had a confirmed COVID case by reported date. And as you may have seen reported, we had this massive spike yesterday of 33,000 cases. All of that spike is England. And really, because the 4 nations are now doing quite different things in terms of restriction, it doesn't actually make that much sense to look at numbers as a whole. So we're going to dig into each nation separately. And we're also going to do it by what's called specimen date. And that is the date that someone has a test. So that is more likely to be related to when they started getting symptoms, which is about 5 to 6 days after they would have been infected. So this is kind of a better way of trying to look at the timeline of restrictions and infection. But it does mean that you can't look up to the most recent day, because it takes time for results to come through. So these are only going up to the 7th of November. And these are charts prepared by Carl Baker. He said I could use them. So you can see here, if I go through it one by one, we'll start with Scotland. Scotland instituted stronger restrictions in its central belt, closing pubs and restaurants there on the 6th of October. And cases kept going up, but seemed to plateau and then came down. It moved into its 5-tier system on the 2nd of November. But now cases are starting to creep up again. But when you actually look at positivity rates, which is a proportion of people who tested who were positive, you can see that for the 3 weeks after the central belt restrictions came in, the positivity rates kept going up in Scotland, which shows that it was still increasing in transmission. It's only just started to come down. And that is exactly also what the Office of National Statistics reported today. And then if you dig in further into Scotland and look at the actual region, so it's got these regional, so this dark red is tier 3, that's kind of high, a lot of restrictions. Orange is medium restrictions, yellow is few restrictions. And here the authorities in green are ones where cases are coming down, and ones in red are where they're going up. And all that really matters here is that most of the places going down are in this tier 3 area. And most of the ones going up, but not all, are not in tier 3. And so now Scotland is moving to move more places into tier 3, but it is a really complex picture. So different regions are doing different things. Northern Ireland, which is this yellow line, had its circuit breaker on the 16th of October. It's a 4-week circuit breaker. They closed schools for 2 weeks and then reopened them, but kept the rest of lockdown going. And it looks, if you just look at case numbers, that it's been working really well, and case numbers have been coming down. However, different things. If you look at positivity rate for Northern Ireland, you see that actually it has stabilized, but it hasn't started coming down. So Northern Ireland is testing fewer people now as well. So it's kind of a really mixed picture. And again, you see pretty much the same picture from Office of National Statistics. So there's some sign that it started to come down recently. We know that hospital admissions are going down, but it's certainly not the case that there's this dramatic decrease. And actually Northern Ireland have just voted to extend lockdown there by another week. And if you compare it to the Republic of Ireland, since they're a single island, you can see that actually the Republic of Ireland is having more success in controlling COVID, much lower positivity rates. And they're now seeing those positivity rates steadily decline there. And just to say, like 20% positivity rates is a sign that Northern Ireland is not testing enough people. Wales is this purple line. They instituted lockdown 23rd of October, their 5 break, 2 weeks. They had closed everything except primary schools stayed open. Again, looking just at case numbers, it looks like it's working and case numbers are coming down. But again, the positivity rates, it's a much less clear picture. This only goes up to the 4th of November. Unfortunately, we don't have later data. There's some sign that they've started to come down, which is good. The Office of National Statistics is not seeing that. And now, of course, the 5 break is over in Wales. So I think the next few weeks is going to be really crucial to see what happens and whether they can stay on a downward trajectory or not there. Finally, let's look at England. English tiers came in 14th of October. It's this line here. Cases kept increasing, stabilized, but are now creeping up again. And we've just literally started lockdown last week. Looking at the positivity rate, it's been going up. So actually, the transmission has been increasing. There's maybe some sign of slowdown. The Office of National Statistics are seeing something quite similar. So, you know, it looks like the tier system has been quite mixed in how it's worked. And you can see this in the regions, and we've seen it in hospitalizations. You see exactly the same pattern in cases where the northeast and Yorkshire are continuing to go up, the northwest is coming down, the Midlands is going up. The places in bold are where the Office of National Statistics says cases are increasing as well. And we can see here that the southwest has now overtaken London in new cases per head. And this pattern is exactly the same as you see in Office of National Statistics. So that's good. That means that our case data is reflecting actual infections. This is just digging into a little bit the spike that we saw yesterday. And what this is number of cases by day of test and not by day reported. And these red bits are when people took the tests that were reported yesterday. So out of the 30,000 cases that were reported yesterday in England, almost all of them were done on either Monday or Tuesday of this week. So that means that they probably got infected Tuesday or Wednesday last week. And so what could that be? Well, I guess one obvious answer is that it's people socializing before lockdown on Thursday, you know, having your last chance to see your friends and family. But it's also just after schools went back after half term. So in a way, if it's pre-lockdown socializing, that's much less concerning because hopefully, you know, that's finished now. So it's a transient spike. If it is a school's effect, then we might expect to see more cases going forward. So the next week, again, in England, we're going to have to keep a really close eye on the data. Just looking at age groups over time, again, this is specimen data, you can see that a lot of the kind of increase and decrease is driven by this 15 to 24-year-old age group, but they have over the last, well, up to 7th of November, slowly started creeping up again. But what's concerning here is that the other age groups are either flat or going up. And the fastest increasing group here is the 80 plus people. It's the oldest and most vulnerable group in our population. And unfortunately, we can also see from this week's Public Health England report that cases in care homes are going up now as well. And we know that that was a really, really big problem in the first wave, and actually something like 20–30% of deaths were from care homes then. And finally, the only other thing I really wanted to highlight, I don't expect you to look at this, but this is the Imperial REACT study, which tested 150,000 people at the end of October, beginning of November. And one of the things they looked at their data by is by people living in deprived areas, so most deprived and then least deprived here, and people living in multi-occupancy households. And all I want you to look at is that compared to the most deprived people, everyone else was less likely to get COVID. And that means the people who are most getting COVID are those who are in the most deprived areas. And also, you're at much higher risk if you live in a multi-occupancy house, 3 to 5 people, and then again, if it's 6 or more people, which we know tend to be the more disadvantaged communities. And also, again, ethnic minorities are more likely to be getting COVID. So just to summarize, Case numbers are slowing down, but the trajectories are still really unclear. Different regions are doing different things, and different areas within those regions are doing different things. So at the moment, it's really hard to say, what is having an effect and what's working. Hospitalizations are going up again in England, and deaths are going up everywhere, but hopefully they will start to plateau and come down soon. Restrictions at tier 3 or more do seem to have an effect everywhere, but it's not consistent. So some places seem to be responding better than others, and I think we really have to understand why, especially as we're now planning for how do you exit lockdown. We know there was a recent spike in cases in England. Hopefully it was kind of a case of pre-lockdown socializing, so it should be quite a transient spike and it shouldn't really affect when we come out of lockdown. But again, we have to kind of keep an eye on that. Probably we'll get another high number today. So the next 2 weeks really are crucial in determining the direction of travel. And we really have to start planning, how do you come out of restrictions? How do you come out safely? What measures do we have in place to make sure that cases don't start going up again, particularly as Christmas is coming at the end of December? And finally, we can see that once again, COVID is impacting on the most vulnerable communities, the elderly and the most disadvantaged areas. And I think that's all from me. And the next slide is introducing the inequalities report by Kamlesh.
Thank you so much, Christina. So yes, now let's go over to Professor Kamlesh Khan, who will say a few words about the new report on COVID-19 and health inequalities.
Thank you, Lucy. Thank you, Christina, as an always clear presentation. So we've now been in this pandemic for nearly 9 months, and we know a lot more than we did 9 months ago. We know something about the transmission, but we do know a lot more because we have some of the best data sets in the world on who gets severe disease and who gets fatalities. But there's still a lot of unknowns. What's become apparent as the pandemic has unfolded is that COVID-19 disproportionately affects certain populations. And we can see this here in this infographic. The green areas circles are the ones where we have good data, multiple data sets, and now confirmation from other studies outside of UK as well. So people with comorbidities, in particular cardiovascular disease, diabetes, kidney disease, they're more likely to be affected. People from ethnic minority groups are more likely to be affected. People who are deprived populations are more likely to be affected, as Christine has just shown. We know that men are more likely to be affected. Biggest driver is the elderly population, and we have good data for obesity. And there are other data about the other factors here that we have some evidence for. So the Independent SAGE published a report on ethnic inequalities in COVID with quite clear recommendations in June. So we'll be not covering that today. That report is on our website. But today, Professor Clare Bambra and Professor Alison Pollock will present the Independent SAGE COVID-19 and Health Inequalities report. This is looking at more wider determinants of health, especially deprived communities, children, occupations, and homeless. So I'll hand over now to Clare and Alison. Thank you.
Thank you, Kamlesh. Let's head over to Professor Clare Bambra and Professor Alison Pollock, who co-authored the report. Over to you, Clare.
Oh, hi, good afternoon, everyone. I'm going to do a short presentation giving some of the highlights from Independent SAGE Report 21, which is looking at COVID-19 and health inequality. And as Kamlesh mentioned in his introduction, we're going to be focusing on geographical occupational inequalities and also on particularly vulnerable groups such as children and the homeless. Our report is quite wide-ranging, and so I will just be picking out a few of the highlights. I'll be giving some of the data on what we know about inequalities in COVID-19. I'll then talk through some of the pathways that we think are creating these inequalities. I'll then touch upon the economic crisis, economic issues, and how they might impact on health inequalities over the longer term. And then I'll conclude by picking out some of the main recommendations from the report. So firstly, in thinking about inequalities in COVID-19, this chart on the left is showing some of the regional inequalities that were that existed during the first wave of the pandemic in England. And we can see here that the rates were much higher in London, but also in the northeast and the northwest. And as we saw in the earlier presentation, this is continuing in wave 2. Indeed, a report earlier this week from the Northern Health Science Alliance found that the northern regions in the first wave had a mortality rate of over 12 per 100,000 extra compared to the rest of England. At a smaller geographical level, when we start looking at neighbourhood level deprivation here in the bar chart, we can see that the bottom 30%, so the most deprived neighbourhoods, have a COVID-19 mortality rate in the first phase that is around double that of the most affluent areas. So for example, in England, the mortality rate in the most deprived 20% of neighbourhoods was around 128 deaths per 100,000 compared to around 58 deaths per 100,000 in the least deprived. And there's similar data for Scotland, Wales and Northern Ireland. Looking more at occupational inequalities, then again, data from the Office for National Statistics, again relating to the first wave, identified which occupational groups for both men and women had the highest mortality rates. And as you can see, it's generally those in more professional occupations, both for men and women, who had the lowest rates, whilst those in service occupations and lower income roles had the highest rates. So for example, amongst men, then it was elementary occupations such as construction workers, security guards and so on had the highest mortality rate of almost 40 deaths per 100,000. And for women, it was those in caring, leisure and other service occupations with around 15 deaths per 100,000. And there is a sex differential, as Kamlesh highlighted in the introduction, but nonetheless quite significant occupational inequalities. Our report also touches upon other aspects of inequality within the pandemic and emerging inequalities that we need to think about over the next 6 to 12 months. So, for example, we have a section talking about the experiences of children gathering together intelligence from different reports and agencies around this. And for example, there's data showing that the school closures affected children living in deprived communities more than their more affluent peers. And there are reports suggesting that more children are falling into poverty over the next year. We also touch upon what's happening within the wider NHS. So for example, with the suspension of some NHS services, such as screening or the switch to virtual presentations in primary care, how that could, due to underlying inequalities in the disease and non-communicable disease and chronic conditions, this could end up with unequal effects into the future. And another area here would be around elective surgery and elective admissions, where already inequalities before the pandemic, and we think these could be exacerbated by the suspensions. This will lead to additional inequalities into the future. We also touch upon mental health, and some of the emerging data from surveys such as the Understanding Society survey suggests that whilst there's been a deterioration in mental health across the country, across all neighbourhoods, this is already slightly more pronounced in the most deprived areas. We also touch upon the rising rates of homelessness and particularly the challenges around COVID-19 protection and prevention within that particularly vulnerable group. It's also important in terms of thinking about what we can do about the inequalities in the pandemic to try and think about some of the pathways that are creating these inequalities. And we'll talk in the report about 4 potential pathways. Firstly, around increased vulnerability of certain communities, perhaps due to the higher underlying burden of clinical risk factors such as diabetes or cardiovascular disease, and how this relates to their existing living and working conditions, and so on. Secondly, we talk about increased susceptibility, so looking at how different population groups might be more susceptible by having weakened immune systems through exposures to adverse living and environmental conditions. The third pathway that we identify in the report is around increased exposure, so thinking about inequalities in working conditions. I'm sitting now giving this presentation from my home, and I've been able to work from home for the entire pandemic, we know this is much less likely to be the case for people in low income roles. So they're more exposed to infection through working conditions. And as Christina highlighted in the introduction in her section, then there's also household transmission. So the fourth pathway is around increased transmission. So the report goes into more detail around each of these potential pathways, and our recommendations try to address some of them. The third issue that I wanted to highlight today is around the emerging economic crisis and health inequalities. And of course, this is a side effect of some of the lockdown and social distancing measures. We saw through to the summer huge decreases in GDP. There are record levels of unemployment on the horizon, with almost 1 million jobs lost in the UK since the start of the pandemic. Economists are fearful that the crisis might be greater than the 2007-8 global financial crisis, and possibly, but hopefully not worse than the Great Depression of the 1930s. This crisis in the economy is already being worse in more deprived areas. So, for example, data from the ONS unemployment data showed that areas of high deprivation, such as Manchester, Liverpool, and Newcastle, all experienced above average increases in claiming unemployment benefits from March through to July. There's various reports from different think tanks looking at the economic impact. And we can see that, again, neighbourhoods where there's already high levels of structural unemployment are more likely to see these increases, certainly now and potentially into the future. There's also the contraction of the economy in particular areas such as retail, tourism, restaurant and pubs is all particularly disproportionately impacting low-income workers because they're most likely to be employed, and this also affects younger people as well. And this, based on previous evidence in public health, could lead to unequal impacts of the economic crisis on health of different population groups. So previous research has found that inequalities emerging from an economic crisis, such as in terms of mental health or suicide, disproportionately affect deprived neighbourhoods, for example. However, as we set out in the report, there's also evidence to show that this doesn't have to be the case. We don't have to trade health for wealth. We can protect people's health through a recession and prevent an increase in health inequalities. So, for example, research looking after the crash in 2008 found that countries that didn't impose austerity did not see an increase in health inequalities, whereas countries which did saw an increase. There's also more historical evidence showing that when you expand social security and provide more social protection to vulnerable groups, such as in the United States or in England, then you actually see a beneficial effect, reducing health inequalities. Whereas when we cut provision and increase poverty, such as child poverty, then we find a different response, and that health inequalities, such as infant mortality rates, can increase. The inequalities in COVID-19 between deprived and more affluent neighbourhoods and groups, in our view, have been exacerbated by the major disinvestment in public services over the last decade through to the policy of austerity. So just to conclude, I wanted to pull out some of the key recommendations. There are several in the report because it covers such a diverse field and tries to take into account different groups. One of the key recommendations I want to pull out today is around how testing services need to be integrated with clinical care and provided locally to address inequalities in people being able to get to testing centres. There's not been real consideration of the costs, for example. We need adequate financial and housing support for those self-isolating to prevent increased workplace transmission. So thinking, for example, about homeless groups. We need that the new NHS reset and restore plans reduce inequalities in access to NHS services that existed before the pandemic and are potentially being exacerbated by it. Longer term, there should be an increase in funding for the NHS, particularly for local authorities and areas that are more deprived, in order to reduce the long-term burden of NCDs in these areas and therefore the vulnerability that certain neighbourhoods have to COVID-19. We also make a number of recommendations about mitigating the economic consequences of the crisis so that we don't have to trade off between health and wealth. For example, maintaining the £1,000 uplift to universal credit and indeed increasing that so that people on benefits are not forced to live in poverty. And a final recommendation I want to pull out today is around a full employment strategy and how national retraining schemes should accompany the work search support package by the government. Thank you very much for your attention.
Sorry about that. Thank you, Claire. Some stark but valuable information there. Now we will be taking some questions from our guests and members of the press and public. First, we go to Jonathan Ashworth, Labour MP for Leicester South and Shadow Health and Social Care Secretary. Jonathan.
Hello. Hello. That was two excellent presentations, and thank you again to all that you're doing at IndySage and for what you've done over some months now, and I suspect will continue to be doing for some months as well. You really have contributed an immense amount to the public debate around COVID, and certainly helped me as a Member of Parliament and Shadow Health Secretary keep informed and influenced my thinking and some of the points that I've been raising, or many of the points I've been raising in Parliament. So thank you for all that you're doing. I was really pleased to come along this afternoon to listen to the presentations on health inequalities, because I think, as many of you know, and particularly Claire and Alison will know, who we've had many discussions over the years, and Kamlesh will know as well, is that health inequalities really is my passion, and was my passion long before this pandemic struck. And I've always thought that there can be no greater social injustice than the stark reality that you effectively can die sooner in life or become ill quicker in life simply because of your lack of means, because of poverty, because of the social conditions that you live in and where or what you work in. And I just think it's an immense injustice that these inequalities are getting wider. And what we've seen with this pandemic is that COVID is particularly cruel to those who are vulnerable to begin with. It thrives on these inequalities. It exacerbates and exaggerates these inequalities. And I think it feels to me that a long-term solution to COVID can't just be about the therapeutics and vaccines. It has to be about a systematic health inequality strategy, tackling these inequities and doing all we can as a society to narrow them. And that's not just the responsibility of the NHS and public health services and so on. It's a wider responsibility across the whole of government and about changing the nature of society. But my question, it's not here to give you a speech. My question, I suppose, is one of the things, but I am a politician, so forgive me. My question, though, is that we have seen in the last couple of years how those from deprived backgrounds, poorer children and disadvantaged communities, it's generally been harder to get the MMR vaccine to them. We've lost our measles-free status in the last 12 months or 18 months or so. And my worry is that as we begin to roll out a vaccine, and I'm not asking about, let's just assume that, you know, they go through the processes and we have the vaccine to roll out. How can we ensure that we roll out the vaccine to the deprived, disadvantaged communities who have been losing out and not accessing vaccinations in recent years?
So, Alison, would you like to answer that?
Thanks, John. As you rightly say, we still don't know enough about this vaccine. We haven't seen the peer-reviewed data at all. And so I think it's a real worry if we focus too much on the vaccine, because we don't know about efficacy, we don't know about which age groups, but it does raise the whole issue of the broader context that Claire and I were talking about, which is the factors which affect your susceptibility to the virus. So in particular, the need for political policies around redistribution of income, of wealth, and to put in place public services. And that means also having really good data to monitor the inequalities in access and services, but also really bold policies around making sure that the rise in poverty, we've got nearly 40% of children who will be below the poverty line now in many parts of the country. That needs to be addressed really urgently through universal credit and benefits, but also making sure that the housing, the overcrowding issues are addressed, the workplace issues are addressed. So I would be very reluctant to focus, and I think it's really regrettable that the BBC and the media are focusing so much on vaccine and vaccine access and not the wider social determinants of health. So I would urge you and the politicians to really look at these wider determinants and to locate vaccine in the proper context, which is if it works, it's a very minor aid and support at best, and to look at the broader social issues, John.
Gabrielle, I believe you've got something you'd like to add.
Yes, I have indeed, and Independent Sage are putting out a statement today about vaccination and welcoming the news about the vaccine. We're also, addressed directly Jonathan's question, we also feel that in discussion of the prioritization of the vaccine, where it is being rolled out, that it should be, when it goes to the local level, it should be used first in the communities where the incidence of infection is highest and where the vulnerability of the population is highest as well. And it's really important that that happens. One of the reasons why is because we know from the data that came from Public Health England about the Manchester area, the Greater Manchester area, that at the end of the last lockdown, the communities that still had the virus freely circulating were those that had the highest deprivation level, had the highest levels of overcrowding, and the highest levels of people from Black and minority ethnic communities. So it is really important that, given the vaccine will flow at a steady pace, we hope, but that it should go to the places and to the people that need it most, and it should go to them first.
Thank you, Gabrielle. Deenan, do you have something you'd like to add to that?
Thanks, and thanks, John, for the question. I would just echo Gabriel's thoughts that it is exciting news. I think the vaccine, but having said that, it is clear that it is there to protect the most vulnerable. That's rather than create herd immunity and reduce overall levels of infection. But I should say I also welcome the fact that this is being rolled out within the NHS structure rather than outsourcing. But of course, the inequalities that Alison and Clare have talked about are equally at play here, in that we know that influenza vaccine uptake is determined by disadvantage and disadvantage. The level of primary care support to the poorest areas of the country, are lower than others. So we've got to be mindful of that, and I think make all efforts to guide how best to increase access to those for whom this is indicated for. Thanks.
Thank you very much, Dean. And Kamlesh Khan, would you like to add to that?
Yes, John, as you know, I work in one of the most deprived areas in Leicester, in Braunston, the fifth most deprived area in Leicester. And we managed to get vaccination rates really high up 30 years ago when I joined, because we had the infrastructure, we had the health visitors. That's where we got the MMR vaccines up for children. If the parents didn't bring the children in, the health visitors went into their homes, they had the relationships, and they got the vaccinations up above the 80% required for elimination of the disease. And so I think, as everyone's saying, like Deenan said, we need the infrastructure, we need the funding within primary care. And I'm hoping that primary care at last will play a major role in the COVID pandemic. As you know, they've been ignored until now.
Okay, thank you very much. I think we'll move on to the next question now, which is from Louise McGee, Director of Policy, Rights and Advocacy for the Child Poverty Action Group.
Firstly, thank you so much for inviting me along, and thank you for such a good presentation that sort of confirms what we'd long suspected, really, about the link of the most serious cases of COVID-19 and deprivation. So I guess my question was to ask if there's a little bit more that the panel can say about the precise role of income in disease and an illness as a result of COVID-19. And then I suppose the wider question is that, how can we get the same sort of urgency around boosting family incomes in the most deprived families that we are putting on the vaccine, and how quickly could we turn this around?
Okay, Zubaida, I think you've got something to say on this.
Well, I mean, that is an important question. I mean, I haven't seen many studies that correlates income with COVID-19 vulnerability, morbidity and mortality. But what I have seen are surveys which have asked the question of different groups in terms of, have you been more likely to go out to work during lockdown or less likely, depending on your jobs and the kind of jobs that you have. And one of the starkest findings I certainly came across this summer was one which Runnymede we ourselves did on Black and ethnic minority communities. It was a survey of 2,500 people where we asked the question of, were you much more likely to go out to work during lockdown or not? And what we found was those in insecure work, 0-hour contracts, and particularly Black and ethnic minority groups in those areas of work were much more likely to have to go to work during lockdown, which of course meant that they were much more likely to be exposed to the virus. And the survey also showed that they did get the virus much more than other groups. So I think that there's certainly that link. And of course, we know, as we've seen from from Alison and Clare's report, from the inequality report, as well as all the other data, that it's the highest rate, that it's in the most highest deprived areas, that it's in the areas with the most overcrowded housing, which tend to be in the most deprived areas. All those factors are correlated to income and therefore to exposure to coronavirus.
Thank you very much, Zubaida. Anthony Costello, over to you.
Louisa, thank you for that question. I mean, I've been reading in the last week that there's been massive rises in household around the country, not fitting from the furlough scheme, huge increases in use of food banks, and crucially, as you will well know, as from the Child Poverty Action Group, access to universal credit often faces delays of 5 weeks or more, which plunges people into loan sharks and debt and the like. And so, it's lamentable that, a Manchester United footballer should be leading the campaign around protecting, feeding school children and stopping hunger at schools. And I'm glad, obviously, that they've U-turned on that twice. But you raise a very important point. And of course, this relationship between, it's a catch-22, isn't it? Those that have been hit worse with COVID are the ones that have the most economic damage, but those that are most deprived to start with seem to have the most problem controlling COVID. I'm moderately optimistic about the vaccine, but there are a whole number of questions. We don't know yet whether it just prevents against serious disease or not, whether it works in the elderly, or whether it actually stops infection. And that's incredibly important to know, and we'll need other trials. I share whoever said, it's going to take time for next year. We don't want to be too negative. I mean, the initial findings look promising. But I agree with you. I think income austerity is fundamental, and very large numbers of children, the UN rapporteur said up to 40% of children are facing poverty in the UK, and that's unacceptable.
Thank you very much, Anthony. Obviously, this is a huge subject and we could talk about this all day, but time restraints mean that we do need to keep moving on. And I'll move on to questions from the press now. Hannah Westwater from The Big Issue. Would you like to speak?
Hi there. Hi. Thanks for having me along. As we've seen in the report, homeless people are at greater risk of COVID, both because of pre-existing health conditions and because of their housing. There are recommendations in the report as to how to prevent a wave of newly homeless people, but what can be done now, specifically policy decisions, to prevent the people who are already homeless and facing a higher risk?
Susan, Mickey, do you want to answer this?
No, I was trying to get in for the last two questions, but not this one.
I'm so sorry. Zubaida?
Yes, no, I will have attempt. I think this links back to some of the things that we've been saying, which is we've made recommendations in our report on Black and ethnic minority communities, as well as, of course, the inequality report, which was shared today, which is very much around the socio-economic support that the government needs to provide with communities. We know that those are the sort of determinants, the social determinants of COVID-19 ill health. And I think around homelessness, there is a particular concern that that's only going to get worse in the next couple of months as government withdraws some of the sort of restrictions around that with landlords. We're also concerned, of course, once again, talking about universal credit, that needs to be increased, statutory sickness needs to be increased. We're concerned that because of as the support, as the furlough support and so on, I mean, we've got furlough for the next couple of months, but jobs will be lost. Jobs will be lost massively in the next couple of months. And we're concerned that that will increase homelessness. So there's a real argument for government increasing the safety, social security safety net much more in the next couple of months.
Thank you very much, Zubaida. Tolu, would you like to add to that?
Yes, just to add to Zubaida's point and to speak directly to the question about what to do with people who are homeless now, I think it's a good point to remember what was done in the first wave. So, you know, homelessness is such a scourge on what is a developed country, and it's apparently insurmountable until the first wave, when there was radical action taken to get people off the streets and into safer housing, to reduce the transmission. And so I think there's some to some extent we've accepted what the things need to be done incrementally, but we have seen that actually transformative action can be taken. So I think it is worth going back to looking at those actions that we're taking the first wave and thinking about how those can be sustained, because they were quite effective at getting people into adequate and safe shelter.
Tolu, thank you for that. And Kamlesh, you've got something to say on this matter too.
Quick point. I mean, as Tolu said, government implemented the Everyone In scheme, which worked, but a lot of homeless people were put into bed and breakfast and homeless shelters where they were overcrowded. And this is where you get the highest transmission rates. So this is where you need to be careful about having enough policies for social distancing, so the housing is right, the ventilation is right. They need to be in the right environment, even if you take them out of the streets. And secondly, healthcare access is always poor for the homeless. And healthcare access has become poor for everyone in this during the COVID pandemic. And I think it's really essential that the healthcare access is reinstated for these populations.
Thank you, Kamlesh. Moving on to the next question, which is Alana Francis of The Voice.
Hello, hi,
Alana?
Can you hear me?
Yes.
Okay, great, thank you. Thanks for the invitation. Obviously, while we know it's important to look at the science and conduct research into the disproportionate impact of COVID-19 on certain groups such as ethnic minorities and those in low income areas, it feels like a lot of the obviously findings, I guess, aren't necessarily a surprise to a lot of us who have been focused on this area. And I know that our readership is really keen to see action taken, which obviously you've highlighted certain recommendations. And I just wondered, I guess, what the feedback has been from the government and what SAGE's plans are, I guess, to kind of push them to really take on these recommendations, because I guess that's really what we need to see if we're going to see any sort of results in terms of addressing these inequalities.
Zubaida, go ahead.
Sorry, I don't mean to take up space on this, but Alana, that is a very, very important question, and one that's repeatedly being raised, because to this day, there's absolutely no evidence that the government have done anything at all to address the recommendations from the inequalities, the disparities reports. The disparities reports talked about how racial discrimination was a driver of health inequalities, but also talked about issues around the lack of PPE for key workers. I think the most that's been addressed is some of the PPE issues for NHS workers. The government are very focused on NHS workers, but there are key workers outside of NHS workers, and there's been nothing done. I think we should have probably taken the signal when the government appointed the Equalities Minister to oversee the issue of ethnic disparities in COVID-19 rather than a health minister. And that in itself, I think, should have sent alarm bells for us. But I think it is really important. Right now, I cannot see any recommendations that the government's enacted on the basis of that report. And I think we need to continue, hopefully alongside journalists like yourselves, to really push for that action.
Thank you, Zubaida. Gabrielle, do you have something to add to this?
Yes, indeed. I think it's really important to recognise the state of the health of the population as we came into this pandemic, because, Alana, what we know is that the improvement of the health of the population, of life expectancy that had been proceeding at a relatively steady pace for about 100 years, it stalled from 2012 onwards. And not only did it stall, but for many people in our most deprived communities, and particularly those communities with the factors I was talking about earlier in terms of the level of proportion from BME communities, the deprivation indices, and for women, that life expectancy has actually been falling. And we have a failed public health system. It has failed to cope with this virus. It failed to cope with inequalities. And I think a big task is to come out of this with whatever review happens to ensure that we have a public health system set up that can help address inequalities at a national level, and also importantly at a local level, because we also know that local directors of public health have been disenfranchised over the years, have slipped down the hierarchy in local authorities, and in many places their finance has been taken away from them to do good work on health inequalities. So coming out of this, it's really important that we don't let inequalities slip past our gaze when we're looking back on this pandemic and how it's been handled. Thank you for the question.
Thank you, Gabrielle. And as a final word, Claire, would you like to speak on this?
Thank you. Yes, I just wanted to suggest that as we have Jonathan Ashworth on as the Shadow Secretary of State for Health, that the Labour Party, as Her Majesty's opposition, consider having a debate in the House on COVID-19 and health inequalities, covering all the issues from this report and from the previous one on Black and ethnic minorities, to try and do a way of putting pressure onto the government and hold them to account for why they haven't taken on board recommendations from this group and also from their own reports by Public Health England.
Thank you, Claire. Moving on, because we are short of time, can I have the next question, please, from Roy Lilly, Health Policy Analyst, Writer and Broadcaster.
You got me?
Yes, we've got you, Roy.
Okay, fine, thanks. Good afternoon, everyone. The data shows that most BAME communities are at higher risk of catching or dying from COVID-19. Should they be prioritized in the vaccines program?
Susan, would you like to answer that?
No, I was trying to get in on the last question. but Kamlesh would like to answer this question.
You're on mute, Kamlesh.
Mute.
Really interesting question, and I've been asked this a number of times recently. The biggest driver is age. So I think that's the priority that we should set. After that, in terms of coming down to minority ethnic health groups, we know that we have a lot of minority ethnic health groups who work within the healthcare system, health and care system, and they are seemingly going to be prioritized, which is good. But then when we come down further down the line in terms of prioritization, it's a really difficult decision whether a minority person who is age 60, who doesn't have any comorbidities, is at a higher risk or a lower risk compared to a white person who has comorbidities. And this is where one needs to start having some sort of quantification of risk. And there is a Q COVID risk score that's been developed. And this looks at general practice data with everything within the practice data that you would have. So deprivation, household, your comorbidities, your age, and that gives you a better precision in risk estimate that if you were to get the disease, what are the chances of you dying from it? So that's a better way of quantifying risk. So I think that's something that may be used, but whether we should prioritize all ethnic minority groups, I don't think we have the data for that.
Thank you very much, Kamlesh. I know others are keen to speak, but I'm afraid I have to move on to the next question because we're short of time. And that's from Tom Magna from Carers World. Tom, are you there?
Yes, I am. Thank you very much indeed. Ready and willing. Our view as unpaid carers, and I stress here, not paid care workers, there's around 13 million of them in the UK. They've two people to worry about, themselves and the person they care for. And this is across all ages. And the increasing worry they're telling us is that if they catch COVID-19, no matter how good the protection they try to put in place, they feel they're going to let down the person they care for. So of the many questions, the one for today is, what impact does COVID-19 have on the human brain as far as can be said at this moment?
Susan, Mickey, would you like to answer this? No? Okay. Anthony Costello.
Yeah, I mean, this is all time.
You're cutting out, Anthony.
Whole long COVID story, that this isn't just a risk of. Can you hear me? Okay, yeah. I'll stop if it's unstable. I was just going to say brain fog. Brain fog is the most important complication where people feel very vague, and this can affect a large number of people who have been in hospital and significant numbers of people who've had relatively mild infection. And this has been going on for months in some cases. So all of these effects, as well as the vascular effects, that is the effects on blood vessels in heart, kidney, and other organs, can have a long-term impact on carers. And of course, if they have other underlying conditions or are older themselves, as many are, they're going to be even additionally vulnerable. So you make an incredibly important point about the interaction between carers and the cared.
Thank you very much. I'm going to move on to the next question now. We've got some questions from the members of the public. Ellie Campbell from Monmouthshire, are you there?
Yes, can you hear me? Hi. Hi, I don't know if you can see properly very well. Right, so I'm an organ transplant recipient, like many people. And so the news of a vaccine has been eagerly awaited for many of us. But there's been a couple little sentences in the odd article of media that says that those with weakened immune systems may not be able to have this vaccine. Is there any truth behind this? Do you know why this may be? And does that mean we have to just carry on waiting until there's a suitable vaccine? Thank you.
Thank you very much. Is there anybody in particular who wants to answer this question? Deenan, go ahead.
Hi, thanks a lot for that comment. The vaccines that are most problematic for those whose immune systems are compromised are vaccines that we call live vaccines, which have the capability to replicate the organism, the virus to replicate and more than would be recommended. And but the vaccines that are now in trials are not that form. And I think a far bigger concern would just be if you're immunocompromised, whether in fact your immune system will respond adequately to that vaccine. So I don't think this is a safety issue, and clearly there needs to be more guidance issued according to the specific immune responses that are being seen. I should say we're very early in understanding precisely how good these vaccines are going to be. We've seen the press releases, and that's of course very hopeful. So I would just be, the recommendation here is to talk the whole time with your, the physicians who are looking after you, and they will be in the best position to guide specifically how best the vaccine could be used when it comes to being available for you.
Thank you, Deenan. I hope that answers your question, Elsie. The next question is from Steph Hanswain from Sheffield.
Hello, thank you for inviting me today. So my question, I appreciate that obviously with the vaccine, everything's still up in the air and we don't actually know too much yet. And the age is the biggest driver for risk. But as somebody who is clinically extremely vulnerable to the virus, to see that we were kind of prioritised 6th at the moment on a list that may change because we're under 65 was quite upsetting. And we feel, speaking on behalf of me and other people in my category, as though we're doing everything we can to take personal responsibility and to shield and to follow all the rules, but then we're not actually going to get the vaccine until after potentially over 12 million other people. So I was just wondering about the decisions around the priority for clinically extremely vulnerable people, because also, in my mind at least, some of us with certain comorbidities would be more vulnerable than some 65-year-olds.
Thank you very much, Stephanie. Susan, Mickey.
Thanks.
Like
Steph, thank you very much for that question. I think the reply I would give, and I would give to quite a lot of questions, is we need much more transparency. We need much more information as to the basis on which these different priority rankings have been given. Because unless we get the information, it's very difficult to know whether to trust or to accept what's being suggested. And I think the same goes for the earlier, more general discussion about the vaccination, is that people need to have really clear, easy to understand, transparent information so that people know why things are being offered in the way they are. And also people know, have the best possible information and be in the best possible situation to make a judgment for themselves or advice to loved ones about taking up the vaccination. So it's not a specific answer, but it's a more general one and a point we've raised before on as part of this group, that we just do need more better, transparent information.
Thank you very much for that question, Steph, and for the answer, Susan. I'm going to move on now because we are very short of time, and we have one last question from the press. Amanda Ferguson, freelance journalist. Would you like to go ahead and ask
Yes,
your
hello.
question?
Thank you for this facility again. I'm sure that Many of your viewers will have seen the circus that's unfolded in Northern Ireland this week around the political decisions over what happens next. The BMA chair in Northern Ireland, Dr. Tom Black, said that the decision that's been taken is not competent, certainly negligent, and a betrayal of healthcare workers. So I was just wondering if you could perhaps address what's happened in Northern Ireland. And the second thing was, in the paper that the Northern Ireland government released yesterday, they said a rollout of vaccinations should be from as early as possible, potentially in December for priority groups. I'm just wondering, like, how realistic is a December date?
Thank you very much, Amanda. Gabrielle, would you like to answer that?
Yeah, hi, Amanda. I mean, it falls to me to answer this since I'm the only one here from Northern Ireland originally. And I must say, I've looked at what's been going on in Northern Ireland with tremendous alarm. And you'll have seen the data in Christina's excellent presentation and the way in which the cases skyrocketed in Northern Ireland for reasons which are unknown. And they are now in an extremely difficult position, and it seems to most objective observers, and particularly members of the medical profession in Northern Ireland, extremely bizarre that the leading political party and the party of the First Minister should want to lift restrictions, and particularly lift restrictions on pubs and restaurants serving alcohol. And in fact, they would have been lifted from midnight to night had that party got its way. It's a most unseemly squabble, and it creates some problems. One of the things that I've learned, and we have all learned during this pandemic, is that clear and consistent communication is really, really important. And what we have seen is a plethora of different positions played out in public. And this has it is undoubtedly having the effect of destroying public confidence in leadership in Northern Ireland. The question is, how did Northern Ireland get there? And again, Christine's presentation showed the difference between the Republic of Ireland and Northern Ireland, and the fact that deaths are occurring in Northern Ireland at 4 times the rate of the deaths from COVID in the Republic of Ireland at the moment is enormously alarming. And my personal view is that the Northern Ireland executive should commission an external review from public health and other experts to see what exactly is behind the catastrophic position in which they find themselves, and to see how that can be put right. And I think the other important point is that it reinforces what Independent Sage has said about the importance of taking an all-island approach, whether we be in Britain or whether it be on the island of Ireland. That was always our view as being absolutely essential. And I think the position that Northern Ireland finds itself now is because of a failure to adopt an all-island approach substantially when deaths were at 0 during the summer and when the number of positive cases was really, really small. They should have pressed on an all-Ireland basis towards 0 rather than ending up where they are now, which is in a terrible position. Thank you very much.
Thank you very much, Gabrielle. Well, that is unfortunately all the time we have for today. Thank you for watching and for your questions. All of our reports can be found on our website. Now we will hand over to Sir David King for the final word.
Thank you very much, Lucy. I think the final word is really about coming out of the present lockdown. What we want to hear about is the government's strategy for managing the exit from the lockdown in such a way that we can see the isolation of the population with the disease from the rest of the population so that we can get on with our business and the economy can fully recover. We don't see a fully functional find, test, trace, isolate and support system at the moment. It's not even close to that. And we really need to hear from the government about the details of how they see the end of the second lockdown occurring in such a way that we avoid the potential of a third lockdown. Now, a vaccine is not available at this point in time and is unlikely to be available when we feel we should be coming out of the lockdown. But of course, in time, we all look forward to the availability and deployment
of a fully functional, efficacious vaccine, one that's been fully tested. We need to hear how that particular strategy is also being developed, the details of the manufacture of the vaccine so that there is sufficient manufactured locally here in England so that it can be distributed locally. And we need to hear details of the deployment which has been discussed at this meeting today. Thank you very much. And thank you again to everyone for coming along and asking these wonderful questions.